Good afternoon, everyone. My name is Amy Scherf. I'm a clinical manager with Indegene. We welcome you to today's webinar, A Tale of Three Cases, Proven Techniques to Engage and Educate Providers. Over the next hour, we'll be discussing reasons why provider engagement is so critical in today's healthcare environment. We'll be discussing the challenges and barriers to effective provider engagement. You will hear about three cases that highlight the implementation of one-on-one provider education. We'll discuss how analytics, intuitive reporting, and innovative platforms can be used to engage providers. And finally, we will discuss how technology can be leveraged in provider engagement. Before we get started, just a few housekeeping notes. We have almost 100 people in attendance for this complimentary webinar, so we will mute all attendee lines. You may submit any questions to the presenters by simply typing your question in the chat box and select Submit to Panelist and Administrator. At the end of the presentation, we will get to the submitted questions, but if we can't get to all of the questions, we will provide an answer via email. I'd like to introduce our speakers for today. Dr. Rajesh Nair is Global President of Indegene. His career spans over 20 years, and he has been one of the leading global experts in the transformation underway in the healthcare and life science industry. As a clinician, he has been at the forefront of evolving strategies relating to engaging providers within the industry and defining the paradigms for improving the efficiency and effectiveness of clinical outcomes. Dr. Barry Patel is president of Indegene TTM, which is Indegene's Quality Improvement and Outcomes Research Division, that specializes in one-on-one provider engagement to support QI. With a vast understanding of the managed care, research, and quality improvement industries, he has always strived to support healthcare organizations with innovative solutions related to effective provider engagement. He presently maintains client relationships and is hands-on as it relates to strategy development and implementation among various facets of the organization. Barry Patel will be our first speaker.
Thank you very much, Amy, and good afternoon, everyone. We're really pleased to have you join us this afternoon for what we hope to be a very informative session on engaging providers. We do have quite a large audience today, so that's proof that this is a subject that a lot of you are grappling with, and so hopefully we'll be able to provide you with some hands-on techniques based on some of the experience that we've had as we present some case studies related to what has worked in the past as it relates to provider engagement. So before we get started and to really set the stage, I think it's helpful to kind of provide a perspective as to where we are. Well, first of all, where we were, where we are, and where actually we're going. And when we talk about where we are or where we were, our healthcare landscape in our system is in a state of flux, in a state of transition, but where we were with regards to where providers were, they were always in a sense of a full autonomy, where they weren't the ones told what to do, but they were actually the ones telling what should be done. I mean, they grew up in an entrepreneurial environment where they were running the show, and at that time, even though there was engagement needed, it was more to align their goals along with other stakeholders' goals. Now, where we are today is the fact that these provider roles are evolving very rapidly with the changing landscape environment. And with some of the things that we'll discuss today as to why that's occurring, you'll see quickly why engagement is necessary on different facets. And then finally, where we're going, we're heading towards a system that is going to require the provider to be pretty much the quarterback of the healthcare delivery model, and in more of a team-based, patient-centered care environment. And in that case, integration is going to be necessary. So we'll sort of talk through how this transition from alignment to engagement or integration is going to be happening within our healthcare system, and also how we have conducted this with some of the organizations we've worked with. So why engage providers now? Again, as I mentioned, where we are today is in a healthcare system that's in a state of flux. But if you look at the left side of the screen, the biggest things that's really driving the changes are the changing reimbursement and revenue models. We're going from a system that was really all about volume of services to the value of services. We're shifting from a system where a provider got paid more to do more, and now it's going to a system of hopefully where they get paid more for doing the best things that leads to the best outcome. So that's a change in mindset from a reimbursement and revenue model. So because of that, providers need to be on the same page and engagement needs to occur. So the other side of that is the performance measures. Performance measures are also integral to the whole reimbursement model changing. And as pay-for-performance programs that are linked to quality measures are put into place, then there are going to be requirements to really engage providers on those levels also. Third, there are incentives for more efficient and coordinated care. We're all obviously faced within the healthcare system to reduce readmissions to hospitals as well as other costly services that could benefit from better coordinated care. And so as providers need to sort of be integrated within that, they will need to be engaged to better understand where those tools and resources lie. And then lastly, something more administrative in the past is now coming to the surface as to also falls on the shoulders of providers, and that's proper documentation and coding, because a lot of the risk adjustment models that are created from the payer setting as well as other organizations that are looking at how to best analyze data, the best documentation is going to be needed there. On the right side of the screen, you see a little bit more of the subtleties as to why organizationally engagement needs to occur. First of all, as we've mentioned, the provider role is changing, and more providers are becoming employees. They are giving up their practices, or at least selling their practices and going into an employment model, or even latest statistics show that medical students would prefer to be employed by a healthcare system rather than actually go into practice for themselves. So that's going to be important to engage them. Also, the second bullet, which is more to provide retention and satisfaction, because now that they're an employee, you want to be able to retain them and keep them from going to other systems. There's obviously increasing demands on provider times. So it's really organizationally how to fit in the appropriate engagement and content that needs to shift these providers from alignment to engagement to integration. So we did, while you registered for this particular conference, you were asked to fill out a short survey, just so that way we could provide feedback on some of the questions and the answers that you had provided as part of from your own experience. So the first question related to what is the reason that you feel is the most important reason for engaging providers, and we asked for you to scale that out on a scale of 1 to 5. And as you can see here from the answers that were provided to us, the biggest reason that got almost a 4.5 out of 5 on an average was aligning providers with changing healthcare landscape and the new financial models. And so I think that's a broad-based topic, but the reimbursement side is also something that is really quickly logging into the fact that the reason for some of those changes. The quality performance measures is also important. As you see, that second, enabling patient outcomes, goes hand in hand with that. And as you see also there, some of the audience members chose that proper documentation for reimbursement and risk adjustment is also a key reason to engage providers. Now, as we talk about what's really driving engagement for various stakeholders across the board, there are different stakeholders within the healthcare landscape. You've got public payers, such as the Medicare and the Medicare Advantage plans, commercial payers, self-insured employers, integrated health systems, even the individual healthcare provider systems, as well as the ACOs. And all of them have different reasons for engaging their ultimate providers in their system. But majority, as you look at across the board, quality measures seem to stand out. For example, for MA plans, the STARS improvement is important, as well as documentation to drive better revenue. Commercial payers have always been interested in improving HEDIS and utilization management. Self-insured employers may lean more towards engaging providers to help with prevention, productivity, of absenteeism. The integrated health systems here, and then all the way to the right here, including the individual provider and the ACOs, I think a lot more is now falling on their shoulders, because as the risk now starts being shifted to these systems, the providers, the ACOs, you see a lot more reasons to engage those particular providers, whether it's patient safety, readmissions, PQRS, all of the above. And so there's a big need to continue to engage. And then the objectives of why, of what you really want to do when you engage. The key thing is obviously knowledge transfer and make sure that the right content gets out to the right provider that you want them to see. Do that in a way that creates enthusiasm in those overall objectives. Build relationships, because this is going to be a long-term haul, and foster that relationship for the long term rather than just give short-term goals as to why you'd want to engage and what you want to transfer in terms of knowledge. And then developing that individual from a career standpoint, just as you would any other employee, because as providers become more under an employment model, self-development and motivational sort of tactics will be part of it also. Now, so the ultimate goal being to integrate providers behind the goal of quality and outcomes. The challenges, as you know, are also the fact that providers have time constraints. There's a sheer amount of volume that needs to be translated to these individuals. And then sometimes you still have to battle the fact that there may be some lack of trust there that is leading to some of the challenges there. So with that said, we did ask a question in the initial registration again related to some of the challenges that you feel are out there. And as you can see, the biggest reason for the challenges is the difficulty in getting access to providers. We'll address that in some of the case studies. But you're right, that is one of them, and as well as the alignment of provider and payer incentives. I think that's getting fixed with our system and the way that these models are working out. And then the fact that the providers are very busy, and so having to find time, which goes back to number one, which is gaining access to the providers. And I'm glad a lot of you didn't think that providers exhibit low interest levels, because we feel the same way. We feel that the providers are genuinely interested. It's just gaining their attention and time with the right information. So some of the models that have been used in the past, obviously there's one-on-one meetings, which is live and in person, or live telephonically, or even live virtually these days. And most of our experience has been in this area, and we've found success in it. But as we all know, this is sometimes unrealistic for the greater population of providers. We can't get to every provider with the right information, so sometimes you have to analyze your data and target just the ones that really need it. You've got group meetings, which are those meetings that are done the same way, but in a group setting, live and in person, via webinar, or even via recorded sessions. And those are effective also, but sometimes lack that personalization effect. Print media and reports, this has always been really the mainstay of provider engagement, getting information to the providers via the mail, fax, email, web portals. As we all know, sometimes they have limited impact because of the passive nature of these sorts of models, but they're still there and they're needed. And then you have digital tools. With this shift towards our technology and being able to leverage technology, there are many digital tools that can be used, and a lot of younger providers especially are used to those. And so we'll talk a little bit about how those are being leveraged out there for provider engagement. The types of content, it's going to vary depending on your need, but across the board, quality measures, formulary information, utilization information, best practice guidelines, healthcare services utilization, contracting terms, you name it. It's going to be different for each organization based on their goals of what they need for provider education and outreach. And so when we did ask the question what the audience felt were the most effective methods of engaging providers, we see here that one-on-one meetings also does rank up there the highest, but also, again, we know the fact that medical directors just sometimes can pick up the phone and talk to some of their providers. That's an effective method, and also the group sessions. And we see a little bit less effectiveness from print media as far as the audience is concerned. So just some general, before we get started in some of the case studies, just some general principles of learning that we've gathered from the literature just to sort of set the stage. Number one, learning occurs best when individuals assume responsibility. So always keep this in mind and consider this, that the providers have to assume that responsibility to take ownership of their own education and learning for them to become active. And we've seen that across the board in literature as well as in our practice. Also, it must be individualized. If it's looked at as a blanket sort of a presentation, then the interest will be lost. Clinicians like to learn on the job, obviously, and problem solve that way. That's why residency programs have always been the mainstay for medical education, as well as a lot of case-based learning occurs within the medical field because it's sort of simulation of on the job. And then clinicians value learning that gives them practical advice and instant access to information, so that's where leveraging technology can come in place. And then clinicians are driven to learn when they feel a level of discomfort and when they feel that their knowledge may not be adequate enough. And so being able to share data with them as to where they currently stand kind of puts them in a sense of discomfort level where they are more open to listen. And then lastly, keeping it personalized and customized and data-driven is what we found to be the key. So I'm going to start with 3 different case studies and talk about how we are, how we have managed this in the past. The dissemination of national, we've conducted a national program with AHRQ on a one-on-one basis. And we are about to talk about some of the data that we were able to put together based on that particular outreach program. The face-to-face model itself has been that we developed for a national program for the Agency for Healthcare Research and Quality was actually modeled from the successful approach used by pharmaceutical companies, where they have been able to work one-on-one with providers. And so based on that model, we put together a model where we could outreach providers on a one-on-one, build rapport, build relationship, and be able to disseminate information related to a particular topic. Typically, it's clinician to clinician, and so it's more of an academic feel, and it's conducted in the office setting. And so this particular project, the scope of the project was to conduct 9,000 of these one-on-one educational outreach visits over a 3-year period. And the fact that this particular program did not have any ties into incentives for providers, as well as it was completely voluntary for the providers to participate, we did actually supersede that scope and actually had 12,475 one-on-one visits, which we'll talk a little bit about the details. There are 6 different comparative effectiveness research topics. Agency for Healthcare Research and Quality has put together CER topics, and the goal of this project was really to disseminate the results from those reports. The audience was over 3,400 different sites, which a majority were primary care practice sites because of the types of topics that were disseminated. And here are the 6 different topics. As you can see, diabetes was related to 2 of those topics. And then we had hypertension and where particular drugs from the ACEs, ARBs, and direct renin inhibitors are to be used. And then antidepressants, topic 4, prevention of fractures, and topic 5, and then treatment strategies for women with CAD. And the materials were posted to the AHRQ website so they could download information from there after our presentation, as well as they were eligible for CE credits if they participated, if they went back on the site. Here are some of the statistics. 63% of the audience were providers, but just we did also work with PAs and nurse practitioners, and a lot of nurses too. In our provider engagement activities, we always make sure we try to include as many clinicians within the practice as possible because it's a team-based approach, and this was one thing that was highlighted in this particular program as far as different types of allied health professionals, and it's not a provider that needs to be engaged. As far as the metrics are concerned, and there's a lot of information on this slide, but the main thing I'd want to call your attention to is the length of visits in minutes that were for these. The first topic itself was about 32 minutes on average. And then it started to go down as we were able to, we didn't need to re-explain why we were there. So that time went by that was less, and then we were able to spend more time on the information itself. Subjectively and self-assessment was provided, and so there's a 1 to 5 scale provided as far as receptivity and interest and intention to use materials. And all of those numbers were very high. In fact, intention to use materials was one of the success metrics, and then whether they had visited the website, and EHCP materials, which is the Effective Healthcare Program materials, started to actually increase depending on the topic. One of the other success metrics that was utilized, because we weren't tracking any specific utilization or quality metrics in this particular case, I wanted to highlight this case because it's more of a broad-based sort of example of how providers are open to actually being engaged just on education itself. And the fact that majority of the providers actually were on 3 or more of the visits. So if a provider was engaged for topic number 1, majority of those providers that were engaged with topic 1 went on to 2, 3, 4, 5, or 6, at least 3 visits. And from the standpoint of the program, since we weren't tracking any specific outcomes related to the translation of that evidence, this particular program was somewhat of a pilot and was wanting to show really the fact that it is something that is well received. And so there were questionnaires that were provided at the end of the program, and majority of the patients, of the providers, in terms of how useful the education was, as well as how well the clinician presented the research, and did they find it to be credible, as well as the biggest thing is, do they intend to translate that research into their practice? All was very, very high for those particular providers that sent in their questionnaires. Now, I'd like to switch gears to a second case study, because what I just highlighted here was more on a broad-based, an audience of providers that actually were voluntary and had no financial incentives, and it wasn't really data-driven. But yet, we were able to access those providers as well as get in and share with them information that would be compelling to them. In this next case study, really going to talk more about how we worked with a health plan, their quality goals, and we didn't go face-to-face in their office, but we actually engaged them through a virtual provider engagement session. And the platform that we utilized is a platform that we have built internally at Indegene called the iClin Engager, which allows a provider to log in to view a one-on-one session by another clinician. So it's a HIPAA-compliant, friendly platform that allows for data to be shared, which is one of the key findings that we've had over the years. To better engage a provider, you have to be able to provide them with their own data. And so by being able to also use webcam technology, as many of you have probably used, obviously, Skype and WebEx and had webcams that you can turn on and off, this is very similar. However, in this case, we're sharing real data and allowing that provider to drill down on their own patient records, because the data is warehoused based on analytics that we've conducted from that particular health plan. And so these just show you some screenshots of the types of programs we use, and then also the feedback loops that then is provided back to that particular provider group practice to allow them to be able to see specifically where some improvements need to be made and where some benchmarking has occurred compared to their peers. So the case study that we did, that I'm going to be presenting here, basically the health plan we worked with, their goal was to improve comprehensive diabetes care quality measures in one of their markets, specifically A1C, LDL, and nephropathy screenings. It was one of the lower markets throughout the whole country. So we targeted the low performers. There were approximately 1,000 providers that were identified through HEDIS administrative data. We invited, and so this was also voluntary, although it was very strongly recommended and suggested by medical director letters and email communications for them to participate in the virtual, what's called an academic detail session, that's what it was termed as. And it's a one-on-one provider outreach conducted by PharmDs with 150 different providers via iClin Engager. We disseminated individualized report and also gave them a link to download patient education resources, so that way the clinicians can really work with their own patients on how to improve in those particular areas, because one of the feedback is always that the provider can do all they're doing, but what can we do to sort of encourage the patient to improve those quality measures. And so the results were that the providers were extremely appreciative of viewing their data and actually being benchmarked and understanding where they stand. And we found that there was significant improvement in the HEDIS measures overall. And then we actually conducted an analysis to compare those physicians that participated in the program with a control group of those that didn't. I had mentioned that we had a name of 1,000 providers. We went down the list based on the low performing report, and we probably reached out to 500 total providers to get the 150 to actually schedule and keep their appointment. And so there were some that didn't go through that audience. So when we compared the providers that did participate to those that did not, we found that those that did participate had statistically significant, more likely to have A1C screenings, LDL screenings, and nephropathy screenings based on their data that we look back at 6 months. So that's a particular case that looked at virtual one-on-one. And the final case that I want to present is really talking through how pay-for-performance models can be supported through provider engagement. And since we are in a time where quality measures are becoming quantifiable now and leading to different reimbursement improvements, increases, or potentially penalties, we felt that this was something that we wanted to highlight as a case and how this could be done. This was a health plan. They were looking to improve HEDIS measures, but primarily doing it because they knew if they could get more of their primary care physicians qualified for an NCQA Diabetes Physician Recognition Program, the DPRP, that it not only would allow the physician to for more opportunity for greater reimbursement, but it would also allow for those HEDIS measures to go up. So we targeted 40 PCPs in 2 different markets. We conducted medical record reviews to do an initial baseline. If we were to submit data today to NCQA for their DPRP status, would they have made the grade? Well, only 1 out of those 40 actually met the status of greater than 75 points. And so what we ended up doing was giving the providers some one-on-one feedback, presented data to them, shared with them some areas of improvement, gave them some tools that would allow them to engage their patients a lot better, and then went back and re-reviewed records 6 months later. 20 of the PCPs continued with the program. We had 20 that didn't even want to continue on because it was voluntary. Those 20 that did continue, we went back and through some of the changes they made in their practice and improvements, 17 out of the 20 now met the DPRP score status of greater than 75 points. So that led, even just those 17 practices led to HEDIS measures improving overall for that particular health plan. And with that said, there were many other changes in improvement in clinical variables. So the learnings that we've taken from these 3 case studies, as well as many of the other programs that Indegene Healthcare and we have conducted in the past, number one, it's important. The content is very important. Disseminate the information that's relevant to that provider. A lot of times they get hit with information that isn't important to them, and they'll tell you right up front, and they'll zone out. So the best way is to make sure that information is relevant. Deliver quality and reimbursement information, but do it in a subtle way, because it doesn't need to be all about the dollars. It needs to be about the quality, and then relay it to how that actually does impact their potential for reimbursement. Third, presenting personalized information is so critical. It ranks up there from our experience as to how can this information be related to their own practice, and that's where we have that ranked up there too, and we feel that's important from a learning. The case-based approach is also goes hand in hand. So if you can first share where they are compared to their peers and national benchmarks, and then use a case-based model, which we'll share with you here in a minute as to what those look like. Those work hand in hand. And then lastly, deploy tools to overall manage other concerns and constraints that they have. The biggest concern you're going to hear from a provider when you go to engage them about quality measures is that I'm doing all I can, but I can't control what my members or my patients do. And so the way to sort of help support that argument to them is be able to say, well, we are going to give you all the tools you can to be able to do that, and we've got some that we can have even leverage technology to do. So you want to be a partner in that with them. So that's another key learning that we've got, that you can't leave them on their own. So with that said, we are going to now sort of transition to talk about how we can leverage technology and basically look at where we can use technology in a sense that be able to drive the provider engagement side, but also the patient engagement side. And so at this point, I'm going to shift the presentation over to my colleague, Dr. Rajesh Nair, and give him the presenter rights, so that way he can walk you through the various types of technology, types of resources that can be put together and have been put together in the past based on some of the work that we've done. So, Dr. Nair?
Thank you, Barry. Good afternoon, everyone. As you would have seen in the previous 30 minutes, Barry showed how exactly Indegene has been able to engage with providers, one on pure education when no financial are involved, and the second scenario where there is alignment around quality metrics which are important for providers as well as for the healthcare payers. So that's the second scenario, and how ultimately by engaging with providers we can improve patient quality also. So, and the last point which Dr. Patel made was it is equally important given the time constraints which providers are going through in today's situation, how we can help them use their time effectively, use technology, use interactive tools, use social media to actually help them improve the outcome as well as the quality of patient engagement. So moving on to the kinds of examples which we have done. As you can see, I'm going to show 3 different types of tools. Obviously, we have over the last 15 years developed a significant variety of tools, but I will highlight interactive cases because in our experience, case-based learning and interactive cases are the most intuitive and engaging methods to work with providers or physicians, as they are very used to that kind of a model. And by developing electronic or interactive methods of handling these cases, we can make it highly scalable. So that's the first example. And then I will show some examples of physician and patient tools. So how do we help physicians help their patients, and what kinds of engagement methodologies and develop? And also an example of how we can take a business challenge which we might have, which is what I'm going to show next, and how we can use a case-based methodology to solve that business challenge. So let me highlight the business challenge. And this is a common enough challenge for all of us. For example, we are doing a risk adjustment, and we find that the quality of coding or the coding errors is one challenge which we might face. So in that situation, obviously, we need to be educating the provider officers. What we have done is using electronic platforms, as you can see from the screenshots out here, we have been able to provide self-service e-modules to physicians as well as the office staff to help them understand what exactly is risk adjustment, what is appropriate coding standards, why it is important. So in many instances, we have found that it's probably lack of awareness and understanding, because physicians obviously are not trained on coding, and also in terms of ICD-9 or ICD-10 coding which will come, they are not really focused on making sure the diagnosis corresponds to a code. So awareness and education becomes an important factor. So the first element would be make sure we have access to electronic, self-service training programs they can use whenever they have time. That's the first part of it. The second part is, obviously, after going through the training programs, now how to actually use it in their work life, that becomes the second part of it. So let's actually take a case scenario. And this is a very interesting case which we found in our risk adjustment kind of analytics practice. This came up where the initial HCC was 12 for a member with malignant neoplasm of the prostate, and the HHS-HCC model was showing 12, and the clinical risk factor was 3.194. Now, when we actually ran through the clinical analytics, and many of you would obviously be running similar kinds of processes, we found that there were evidences for hypercalcemia. There was evidence for bone fractures. We had a prescription for zoledronic acid. So essentially, obviously, this was a case where there was a malignant neoplasm which is metastasized. So obviously, the risk factor should be higher. And we found that obviously there is a significant difference in the dollar amount attached to the higher risk factor. Now, once we found that this is indeed a scenario, now I will show you how we will convert this kind of documentation gap driven by potential lack of awareness, how we can convert that into a case. And this case, as Dr. Patel was highlighting earlier, we use the iClin Engager platform, but we will define a 5 to 10 minute short clinical case, which will essentially, as you can see, highlight a patient with similar kinds of conditions. And we will ask the physician to go through this interactive case, and as you would see, there's the question, there's asked what's the diagnosis, and during this interactive case, we would make sure there are appropriate messages being embedded. For example, make sure at this point in time, this is the code which has to make sure that you do not forget to document for, say, a hypercalcemia, those kind of situations. So this is an example of how we would convert a business challenge into a self-learning interactive case model, which can then be used to improve the overall outcomes. Now, let me now highlight actual interactive cases. Depending on the quality of the bandwidth, some of you might not be able to see the video. There are some of these which have video. I apologize in advance, but let me start off with the actual interactive case. So this is an example of how we are developing a case which helps the provider practice see the overall context of renal failure, chronic renal failure, as well as end-stage renal disease, and also kind of educate everyone on the team which is managing this process. So I will start off the case study out here.
Let me give you an overview of the three cases. In Case 1, George has CKD diagnosed by a nephrologist. In Case 2, Joanne has a new diagnosis of ESRD. In Case 3, Dan has been on dialysis for several years and received treatment in the hospital during an emergency hospitalization for a cardiac event. Let me now introduce you to Dr. Robert Provenzano, who is the nephrologist in this program.
Hello, I'm Dr. Robert Provenzano, and welcome to the virtual CKD clinic. I see you have met my colleague, Ms. Cooper, who is a nurse manager at our clinic. I will be reviewing 3 cases that Ms. Cooper has already introduced to you, and will manage them as indicated. Let me tell you a little bit about myself. I've been a kidney specialist for over 20 years. I am dually board certified in internal medicine and nephrology.
Hello, my name is Ms. Williams, and I'm a nurse practitioner. I will show you how we care for George based on Dr. Provenzano's treatment plan. 2 weeks ago, during George's initial visit to the CKD clinic, I told him about the associated risks and complications of his disease, and also reviewed his overall treatment plan. This education is important to ensure patient ownership of his health care and would increase the likelihood of compliance with treatment.
This interactive case helps in converting identified business challenges which has an impact on quality or an impact on coding or impact on documentation. Convert that into interactive educational experience and also bring together the overall organization on the same page. So this is one example of how Indegene develops these electronic or virtual education modules. Another one which I want to highlight is essentially around how we can use tools for patients and help physicians engage with their patients and help them manage their condition. So I will highlight. This one is a video, so it might have some stuttering, but let's actually begin with that.
We represent the different healthcare professionals who typically work together to diagnose and treat patients with carcinoid syndrome.
We're here to help answer some specific questions about carcinoid tumors and other related topics.
So as you can see, here we have the full range of all the care providers who are involved in providing care for the patient. So we can choose any of these care providers and who are typically seen by the patient as they go through their journey, and then find out what their questions or queries are and find the appropriate answers to them. So let us take the oncology now and ask some questions from her.
What would you like to know about more?
So assuming that we find that in a physician's office, a lot of time is spent trying to help patients navigate basic information. What here we are trying to do is to convert these basic standard questions into an electronic interactive format, which will help physician offices reduce the time spent doing direct one-on-one interaction. So let's assume the question is, how should I prepare for my test?
The first thing you should do is make sure that the healthcare team has your complete medical history, including all the medicines you take. One of the tests used to diagnose carcinoid tumor measures the blood level of a chemical known as chromogranin A, or CGA. However, false results can occur with high blood pressure, gastritis, certain tumors, and heart or kidney disease.
So as you can see, we can have a platform where all the regular questions or the basic questions which our patients might have can be converted into a tool which the physician and his staff or her staff can obviously convert into an electronic tool. And it can go from what is the disease, what should I do, how should my lifestyle be changed. So all of those questions which are important from our physician, right, quality and outcome, we can pre-package them as electronic tools, interactive tools, and help the providers engage with their patients and thereby allow our clients to engage with the provider. With that said, I will ask Dr. Patel to continue the program, and this is just was a quick overview of the various interactive elements, but obviously there are many more, but I hope that we have been able to show you a broad sense of what is possible, what are the tools which are underway in the marketplace, and how we can take advantage of it. With that, Dr. Patel.
Very, very good. Thank you very much. And I think that does really highlight some of the, especially the point I brought up earlier about the fact that providers are always going to say, what can you do to help my patients? And that's where these sorts of tools can be customized, built for particular health plans or health systems that want to get their customized information, not only to patients, to providers, to engage them through technology. So that's very helpful. So I do see that there's some questions. We have about 10 minutes left. We have some questions that have been sent in via the chat feature. So I'll hand it to Amy to go ahead and read off some of those questions.
Okay. Well, I'd like to thank the speakers for a great presentation. We appreciate your time. We hope this was an informative webinar that leaves you with a few new ideas that you could possibly apply within your own organization. And I have a few questions here. One of the first questions, based on your past experience, what is the single most important ingredient needed to properly engage providers?
And I think we highlighted that in some of the slides, but the key ingredient in our experience that should be considered is really utilizing providers' own data and being able to benchmark their own data to their peers and possibly even national statistics, and be able to really present that back to them in a personalized fashion that isn't threatening at all. So I think that's the key thing there, and also being able to understand the other ingredient I would say is try to figure out which interventions are going to be the best ones for your particular providers, because different providers react to different engagement models, and to be able to use past history from your own organization, as well as the literature is a wealth of information too as to what works, as well as organizations like us or other vendors that actually have done these, really lean on them for their expertise on what would work for certain types of providers.
Okay. Besides the physician, who, in your opinion, is the provider practice would be the key to provider engagement?
The provider, obviously, from the physician standpoint, is the one that's actually going to be calling the ultimate shots. But in our opinion, actually, believe this or not, the office manager holds the keys to the rest of the practice. And if you can get to them first, get their attention, they will allow in and serve as that gatekeeper to get into not only the physician themselves, but to other clinicians, nurses, nurse practitioners, as well as medical assistants, because these days everybody's involved in the care and can impact a quality measure, especially quality measures such as screening rates and things like that, that a provider may tell, a physician may tell the patient that they have to do something, but it's really for the rest of the staff to follow up. So if you can get to the office manager, explain the goal of the engagement, as well as sometimes the reimbursement implications, then that's going to always be very helpful.
Thank you. You talk about leveraging technology. How can we leverage EMR systems to engage providers, since this is basically at the point of care?
Yeah, it's a good question. Basically, if you're a payer, obviously you're working with your health systems or providers that might have EMR, so you don't have direct access to those EMR systems. But if you are a provider group, you can leverage the EMR alerts and other things that might be available through your system at the point of care to engage. But what we found from our past experience is that a lot of providers, and the feedback that we get from providers, a lot of providers tend to then just click through certain screens, even if the EMR alert comes up that this patient should be, for example, on an ACE inhibitor. And it's just second nature to say, okay, well, this keeps popping up, so let me just kind of click through it. So EMR, it needs to be sort of the foundation for the information gateway on a specific patient basis. The usefulness from engagement of a specific provider, it needs to be sort of a side engagement strategy.
Okay. Do you have any specific advice for engaging providers in improving documentation? We use random individualized chart data, but we'd like to refine our approach if possible.
Well, definitely chart data is going to be the most credible, because that's actually what's been documented so far. So to be able to feed that back is going to be key. The advice that I would have is to be able to summarize a sampling of charts back to that provider, to be able to show a trend as well as specific drill down to specific charts in that information. If that information, whether it's an electronic medical record or a paper-based chart, if there's ways to take data fields and summarize those into reports and let a provider know that it did come from their charts, that's going to have a lot more impactful information rather than if administrative data is used. And so I think the question really was what sources, what might be the best way. And it's a combination of all, but the chart, if you can gain access to it efficiently. A lot of organizations have ways to be able to gain and store medical records, whether they're collecting it for HEDIS and then they can potentially use it for other things, then definitely that's what I would suggest.
Yeah, and if I might add, I think this is a common enough question which we see, and obviously the biggest issue is how do we make sure the provider's interests are aligned and incentives are aligned with our business interests. That is really important because you cannot force someone to do something if it is not really helping them in doing or driving their outcomes. That's the first part of it. So apart from doing whatever structural designs for the incentive part of it, the most important thing which I would like to highlight is that we need to really look at each instance of provider, office, or even an individual physician as a case of one person and then try to solve that. Unless and until we understand why the situation is happening, we won't be able to solve the problem. And in our experience, what we have seen is, obviously, once we start figuring out why the situation is happening, why documentation is not effective, it might be because one, lack of awareness. So in which case, you can have a self-service e-learning module provided as a tool. On the other hand, it might be lack of understanding of specific use case scenarios, in which case you can have a one-on-one session, or you can have case studies which are highlighting these kind of situations. In some other instances, it might be because as a group, the providers are using some kind of a, if I might use, a cheat sheet, which might be asking them to follow a certain approach, which is not appropriate with the coding standards required or documentation required. So it might be because of different reasons, and we can solve the problem once we understand exactly what is driving the problems in documentation.
We have about 2 or 3 minutes left, and we have time, I think, for one more question. What are some return on investment metrics that you have looked at in the past for certain engagement programs?
ROI is a big question, and I figured that one was going to come up, so I'm glad somebody did ask that question. So it's different based on every program, obviously. When you're engaging providers, you want to sort of bucket out the different strategies that are being used. So analytics have to be part of that solution to know what's working, and we've been able to create dashboard reporting to understand which interventions are having an impact. But as far as the actual return on investment, so obviously there's a cost to every intervention or every engagement. How do you measure the return? The return, on some cases, and it all depends on the program. So we've done programs where we're looking at pharmaceutical utilization, where it's brand to generic sort of education. Those are easily measured because you're able to measure what % brand to generic is converted, and specifically down to the provider and to the patient level. When it's improvement in HEDIS measures and quality measures, those sometimes could be extrapolated. For example, the DPRP example that I provided, sometimes that could be extrapolated as to now the fact that they are, the DPRP status is reached, their reimbursement is going to increase by X dollars. And so for that provider group, there's a significant ROI there. And in other areas where it's just as Rajesh had mentioned regarding documentation and coding, those are also easier to measure because you're able to then tie back what different documentation changes that started to occur with a provider that now leads to better risk-adjusted patients that are submitted back to not only for Medicare and CMS, but also for new health insurance exchanges now that are required.
Okay. Last question. How can payers work with providers to gain access to their EMR to help facilitate better outcomes and reporting?
So payers do have access and they do have the right for the medical record, obviously, for quality improvement purposes. It's just going to depend on that health system and how easily they can make those records accessible. When we've worked with payers and they have large IPAs or large health systems and we go in on behalf of that payer, a lot of times they'll just let us sit in and access their records just as one of their employees, just because of through the business associate agreement, as well as sometimes they'll be able to download the specified records on a zip drive and then send it either to the payer directly or to any covered entity or vendor. So it's just exploring the different avenues and maintaining that relationship with the provider. So if it's a large physician group, for example, with 20 providers, there's usually going to be somebody within that's managing all the EMR and the information. And being the payer, you obviously only have access to those that are covered by you, but that still is something that you have the right to, and being able to build that relationship. We've been able to be successful in gaining that access remotely as well as directly on site.
Okay, well, I think that winds this up. We will respond to any questions that we couldn't get to via email. All of you will be receiving a copy of these slides and a link to the recording. This webinar series is brought to you by Indegene Healthcare as a service to the healthcare community. Indegene has provided cutting-edge, provider-focused quality improvement programs for over 18 years, and we've worked with many of the organizations that have dialed into this webinar, and of course we look forward to working with you again in the future. For those not familiar with Indegene, if you'd like more information, please don't hesitate to request a demo of any of our new technology tools focused on provider engagement and quality improvement. We thank you for spending this hour with us, and we look forward to talking with you on a future webinar event. Please remember to submit your feedback survey, and have a great day.